to the Antra Health Podcast. I'm super excited to have our first fertility-focused guest. So today we have Dr. Sharon Moayeri. Did I say that right?
Moayeri.
Oh, Moayeri.
Yeah.
Okay. Today we have Dr. Sharon Moayeri, the founder and medical director of OC Fertility and also OC Biogenics based in Newport Beach. And you're also double board certified for reproductive endocrinology and infertility, as well as obstetrics and gynecology. So super excited to have you here. I'd love to get a sense of your background from your point of view and also how you got involved in two companies, OC Fertility and OC Biogenics.
Sure. Thanks for having me first and foremost. It's great to be here. I love being up in Venice Beach, close to where my son is, so that's always nice to come up here and visit. So, and I'm excited to learn more about your company too. But myself, I started OC Fertility back in 2009, mainly because I wanted to create a company in reproductive health that kind of focused more on my interest, which was patient experience, and also maintaining that high level of scientific technology. So medicine obviously is focused around science, but also patient experience, and it was hard to kind of meld those from a woman's perspective.
Right.
So OC Fertility kind of evolved through basically really not having that opportunity out in the community. And then over the time that I was developing and growing OC Fertility, realistically, we have a big dependence on an IVF lab, and I had partnered with some others in an IVF lab and decided that it made sense to kind of do my own separate IVF lab on site, also to improve the patient experience and create OC Biogenics on site so that this experience for patients was seamless. So the clinic practice and the lab practice are all in one location, really to give patients this holistic, safe patient experience, and kind of fulfill what my kind of dream was coming out of fellowship, truthfully based a lot on where I trained. This model of a seamless patient experience that's inclusive and in my hometown.
Yeah, that's
Oh, I did my OBGYN residency in my hometown in UC Irvine.
Okay.
And then I went up to Northern California at Stanford for my residency.
Awesome.
For my fellowship in reproductive endocrinology.
Cool.
Yeah.
So what does it look like when the lab is separate from the clinic?
Yeah, that's kind of a unique thing, I think, in Southern California, because where I trained up in the Bay Area, we didn't see that very often. Mm-hmm. But coming down to Southern California, it's quite common to have the clinic practice off-site from the lab, and that was kind of unusual for me.
Yeah.
And in fact, sometimes even the procedure suite where we retrieve the eggs is separated from the lab. So you kind of have three locations: the clinic, where you retrieve the eggs, and then where the lab is. And that was really different for me. And it works. I mean, a lot of places do that down here in Southern California. But for me, I just felt like very disconnected. And so that's really how I ended up forming OC Fertility and then eventually forming OC Biogenics.
Right.
Yeah.
So it does improve the quality to have them be in the same location?
I feel, I don't want to criticize the quality of other places that don't have it that way, but for me, I felt like, it created a better continuity, better communication between the entities, and a better patient experience. I feel like there's less room for things to go wrong because everything's in one place.
Yeah.
And, I feel like patients are giving us feedback that they feel, it's a stressful experience. And if they've been in the clinic throughout their treatment, to then have to go to a new place for one procedure and then to communicate with yet another entity about their embryos or their eggs or their sperm, it kind of creates a lot of extra burden on the patient. And so I feel like having it all in one place really makes it less stressful for the patients.
Yeah, that's awesome.
Yeah.
We're sort of similar to what we do, I guess, in a sense, because we work with the lab, but yeah, we try to limit, honestly, communication to an extent for the patient,
Right.
because we don't want them to freak out about product quality or what have you.
Yeah.
So yeah, we try to just make it all like a seamless experience.
Yeah, I mean, it's a lot. Patients have to absorb a lot of information, right. And realistically, they're only able to absorb so much in one setting.
Yeah.
When I do a consult, I might talk to a patient for 45 minutes, and realistically, I only expect them to absorb a small portion of what I tell them.
Right.
So we do try to complement that with a lot of written material, content on our website, and then reinforcement. And so then to expect them on top of that to be not only absorbing the clinical information, but then to try to navigate the administrative aspects of their care, it's really a lot to expect from people.
Right. Yeah.
And our patients are highly educated. So, I look at it and I think it would be really difficult for me to do it. How do I expect my patients to do that?
Yeah, it's super interesting. I follow these influencers, Francesca Frago and her fiance, who's transgender, and so they're doing. They're both going through an egg retrieval process, and then they're both going to try or only Francesca is going to try and use the eggs from either of them. But yeah, it's really interesting to just see how they perceive that whole process and present it online. Like Francesca has PCOS, so she ended up having a complication with egg retrieval and things like that. But yeah, there's just so much information that I feel like they even relate to their audience. And yeah, that's just, it's kind of information overload.
It is information overload.
Yeah.
But it's powerful if you can enable patients to digest it, in a way that they can feel like they understand and have the expectation of what's coming.
Right.
Okay,
awesome. Cool. Well, before we delve too deep into genetics testing and fertility and things like that, I wanted to get your take on cord blood banking, because we at Anja Health do cord blood banking. So I was wondering if you happen to do cord blood banking for your son and or other kids that you may have. And what your kind of encounter was as a parent, and then also as a physician, as an OB/GYN and reproductive endocrinologist.
Yeah, so I had both of my kids in residency. I have a son and a daughter, and that was back in the early 2000s. And I have a father who's a medical oncologist, so he was adamant that I had to do cord blood banking, and that was kind of in the early stages of cord blood banking, and there weren't many companies doing it back then. So I did do it, and I had no idea, if I would ever need it. And luckily we were in the position where we could do it financially. It's obviously costly to do. And so, for me, it was something I felt was important.
Yeah.
And so I think it can be a very valuable tool. And clearly there's private banking and public banking. And so in my mind, it was, lucky to be able to do the private banking. And I felt like at some point, maybe if we didn't need it, we could always potentially contribute it to public banking.
Yeah.
So I felt like since we have the resources, why not?
Yeah, that's awesome. What kind of stance did your father have as an oncologist?
Oh, he was very adamant I had to do it. I didn't even have a choice. And he's like, we'll pay for it, so because I was on the fence a little bit, because is it worth it? Is it not? What's the clinical utility? And he's like, just do it. You never know what the future is like with it. And so we did it. And we haven't obviously, knock on wood, needed it. But you never know. And someone else might need it at some point. And so having it there, I think, is useful.
Yeah, definitely. So if parents ask you your views on cord blood banking, what do you share with pregnant parents about it?
Yeah, I think it's definitely, if you have the resources, and luckily a lot of our patients do, I think if it's not going to put you out too much and you can afford it, then I think it's worth doing. There's definitely opportunities with public banks to seek those, but you may not get what you need from a public bank.
Yeah.
So if you can privately bank, I think it's worth it.
That's awesome.
Yeah, it's a good, it lowers your risks in the future potentially.
Yeah. Yeah, it's interesting that you mentioned your dad's an oncologist, because I feel like oncology, I think it's about 50% of the clinical trials going on right now related to cord blood are oncology related, and the remainder are cardiovascular and musculoskeletal disorders. But so awesome to hear that he had a pulse on it even back then.
In the early 2000s,
Yeah. Awesome. Well, I was wondering if you had any questions for me around cord blood banking.
Well, I'm curious because there's so many companies now that are doing it, and
Yeah.
I understand you got into it because of your brother. I understand,
Yeah.
and sorry to hear about that. But like, so how do you see your company kind of like what separates your mission from these other companies, and how do you see your company kind of evolving amongst all these other companies?
Yeah, well, I think kind of along the lines of the mission of your company, like we always wanted to prioritize patient experience, because I think a lot of parents find it really hard to sort of perceive how to understand cord blood banking and just how it works. Like I get so many questions around like, I was never even informed of this in the first place, but also we've gotten comments around like, oh yeah, I remember getting a pamphlet, but I didn't feel like it was easily understandable and felt sort of out of touch. So yeah, I think patient experience is a big one. So we try to make information super accessible. That's why I think things like this podcast are really interesting because we're able to sort of package it with information that's helpful for pregnant parents anyways. And then we also try to have more accessible pricing. So we're about 30% more affordable than the industry average. And then we have different payment plans that parents can choose. So they don't necessarily have to pay like thousands up front, but can sort of pay over the course of interest-free payments. And then we also have manual processing in our lab rather than automatic processing. So that allows for us to really be able to maximize the stem cell count if they're able to really personalize sort of the stem cell extraction that's happening. For instance, if there's particularly low cord blood volume or shorter cord or smaller placenta. So yeah, those are the main differences.
Interesting. Yeah.
Awesome. Well, I know that when we chatted with your coordinator earlier, she mentioned that you were really interested in genetics testing and just everything around that. So I'd love to move into a portion of our episode where we chat about genetics.
Sure.
So I know we actually asked in our onboarding form if our parents have gotten genetic testing before. Originally it started as just sort of like a better way to understand our users, but yeah, it's been kind of interesting to just get a sense of their history and also potential future need for cord blood stem cells.
Yeah.
I'm curious your take on if you really need genetic testing during pregnancy and if you would recommend it to all parents.
Yeah. So genetic testing is complex because there's so much, there's so many different types of genetic testing. So I like to break it down to genetic testing of the parents, so the sperm source and the egg source, whether it's, then the actual people who are raising the kids or if it's an egg donor or sperm donor.
Yeah.
So I think it's important, in my opinion, especially the patients we're seeing, because some of them are having trouble getting pregnant. So if you have the opportunity to do genetic testing pre-conception, I think it's valuable. A lot of people are getting pregnant unintended or accidentally, so it's not necessarily true that they have that opportunity, but if you do, testing the egg and the sperm source is very helpful. And so what tests would you want to do with the egg and the sperm source? I think carrier screening is really important to look for any hereditary unknown diseases that the parents may carry. And carrying a disease doesn't mean that you express the disease, but if you breed with someone or have a child with someone who also carries the same disease, then 1 in 4 of your kids can inherit 2 copies of that gene and actually express the disease.
Right.
And people don't know that until they have a child with that disease. So an example could be cystic fibrosis or muscular dystrophy. And in fact, we take care of patients often after that. It's already happened to them, to their families. And so, people say, well, we don't have any family history of it, but that doesn't mean that you don't carry a mutation.
Yeah.
And just because you don't have a family history doesn't mean you wouldn't necessarily develop a family history by mating with someone who carries the same gene. Right. So I think those things are hard to predict, and so you probably want to do that preconception in the 2 parents. And then the other test that I think could be valuable, but probably less likely to detect a problem, but certainly if you're having trouble getting pregnant, it's worth pursuing what we call a karyotype in the parents. And a karyotype just looks at the structures of the chromosomes. So whereas a carrier screening looks at typos on the chromosomes, karyotype looks kind of more like at a picture of the chromosomes to make sure that the chromosomes are correct in number and in the right place. So people who have trouble getting pregnant might have chromosomes in the wrong place, even though they have the right amount of chromosome material. We call those structural rearrangements. And even though they're fine, when they go to reproduce, they can create a lot of chromosome errors in their offspring. and have trouble getting pregnant, or those errors can lead to congenital birth defects. So I think it's important, especially if you're having trouble getting pregnant, that both parents, both the male or the sperm source and the egg source, have karyotypes as well. And people often don't think about the karyotype. They focus a lot on the carrier screening, but I think both can be really important.
Okay.
And then once you're pregnant, there's further testing you can do. And in fact, in fertility treatment, you could also do embryo testing. I don't know if you want to get into that, but there's also genetic embryo testing that can be done. We call that pre-implantation genetic testing. And there's several different tests you can do on the embryos. I don't know if you want to go into the details of that.
Sure.
Okay, so on the embryos, so once you harvest eggs and create embryos from the egg and the sperm, you can actually remove some cells from those embryos after they've developed for about a week, and you can count the chromosomes, and that's called aneuploid testing. So anu is abnormal, ploidy is number. Mm-hmm. So abnormal number of chromosomes screens for the more common type of chromosome errors that we see with reproduction. So like Down syndrome, trisomy 21. When the egg and the sperm come together, errors can occur, and those errors occur more frequently as we get older. Mm-hmm. And so that's a common reason why we have trouble getting pregnant and why we have increased miscarriages as we get older. Mm-hmm. And so we can actually test for that in the laboratory before the embryos go into the uterus. And that testing, again, is pre-implantation genetic testing. PGT is the abbreviation for aneuploid screening. We can also, once we remove those few cells from the embryo, screen genetically for other conditions. Like I previously mentioned, the carrier screening, if we knew that the parents each carried a mutation, for instance, for cystic fibrosis, we can also then use those same cells to look and see if there's 2 copies, 1 copy, or no copy of the cystic fibrosis mutation. Mm-hmm. And in that case, we're doing PGT for mutations. Right. So that's abbreviated PGTM, okay? So people get confused because they sometimes don't know what all these abbreviations mean. But you only really need to do that if you know that the parents are at risk. That's why preconception testing the egg source and the sperm source is really important.
Yeah.
And then the third thing you can do is looking for rearrangements in the chromosomes. But again, you would only be doing that if you knew that one of the parents had an abnormal karyotype. Mm-hmm. That's why, again, it's important to screen the parents. So the latter 2 screenings in the embryos, the PGT for mutations and PGT for structural rearrangements, really only need to be done if the parents were at risk based on preconception testing. But the aneuploid screening, the PGT-A, is a random event that happens at every time an egg and a sperm fertilize, mm-hmm. and could be done at every IVF cycle.
Okay.
Because that occurs randomly every time.
Yeah. So
okay?
Is there anyone that you think in particular should be definitely looking at preconception testing, or would you just blanket recommend it for anyone conceiving?
Well, if you get pregnant and have, easily, then it's probably not necessary.
Yeah.
But I think carrier screening probably is useful for a lot of people. But again, it's costly for some people, and it may not be easily, accessible for everybody.
Right.
But certainly if you're having trouble getting pregnant or having repeated miscarriages, I think it's very important.
Right. Okay, awesome.
Okay. And then once you're pregnant, of course,
yeah.
Then there's further testing you can do during pregnancy. So we can go through those as well.
Yeah, for sure.
Yeah. So during pregnancy, there's non-invasive prenatal screening, mm-hmm. And that's done as early as 10 weeks.
Okay.
And in that instance, we draw the mother's blood, mm-hmm. to extract the fetus's DNA. And you can screen for chromosome errors in the fetus, specifically chromosome 13, 18, 21. And then we also look at the sex chromosomes to see if there's extra DNA of any of those. And so you're looking for things like Down syndrome, Edwards syndrome, and Petau syndrome, as well as chromosome errors on the sex chromosomes like Turner syndromes and Klinefelters. So it's a screening test, so you want to follow that up if there's any errors there. You can also find some other conditions that are called microdeletions. So it might not be the whole chromosome that's excess. It could be small portions of the chromosomes that are, for instance, missing. Mm-hmm. DeGeorge syndrome is a common example. That's a small portion of chromosome 22 that's missing. That's pretty highly common, second in line to trisomy 21. Mm-hmm. And that cannot be detected currently with the embryo testing. So it's useful to do the NIPT or NIPS at 10 weeks to detect those microdeletions. And if any of that is abnormal, you want to follow it up with a more definitive test, because you're not really getting a lot of DNA with the NIPT. And so the definitive test would either be a CVS, chorionic villus sampling, as early as 12 to 14 weeks in pregnancy, or an amniocentesis, which is done later in pregnancy.
Right.
Both of those involve a little bit more risk because you insert a needle through the for the CVS, either through the vagina, typically through the vagina, but sometimes through the abdomen to get to the placenta and remove some placenta cells. And then for the amnio, typically through the abdomen to remove some fluid in order to get the fetus's DNA. But you get a lot of cells, and so you can really amplify the DNA.
Okay, interesting. Yeah, my next question was what kind of risks are involved in different types of genetic testing? Like, I feel like especially in media, for some reason, I perceive a lot of concern around amniocentesis, and that's, I feel like, really frequently depicted in pregnancy-related media.
Yeah, I mean, so you don't want to do an amniocentesis on everybody, but generally speaking, it depends on who's doing the amniocentesis. And I think some of the data that you see in the media and in the literature is based on old information before ultrasound technology was so good, especially for CVS, because our ultrasounds weren't that great years ago, and now they're very good. And people's skills weren't as good as they are now. But generally speaking, the risk for amniocentesis or CVS is less than 1% in good hands. But you don't want to do it on everybody. We usually think about, like, who do we do it on and who don't we, based on, what's the risk of finding an abnormality and what's the risk of the procedure and where do those risks intersect.
Right.
And that's kind of how you decide who should you do it on and who shouldn't you do it on. Okay.
Awesome. So does insurance typically cover genetic testing? I know we chatted about sort of you should do it if you have the means.
Right.
But under what circumstances is it that you don't necessarily even have to have the means?
Yeah, so it really, in my experience, and this is probably better for my admin team, but it really depends on the plan, whether they cover it or not. I think what I understand now in California, they're mandated to cover the NIPS or NIPT, depends on which company, what they call it, at least for trisomy 13, 18, 21, and I believe the sex chromosomes. And so in California, I think it's mandated that they have to cover for that.
Regardless of your current, like, family history or anything like that?
Yeah, I think in pregnancy that's required. And that's not a carrier screening, that's looking for aneuploidies. So that's like when the sperm and the egg come together, there could be chromosome errors. And the reason why we're only screening for those 4 chromosomes is because if there was an error in the other chromosomes, the pregnancy wouldn't have made it that far. So we're only screening for those 4 chromosomes because we have limited DNA. And so we have to make some choices. What are we going to screen for?
Right.
And so we know that statistically, those are the only ones that are compatible with life at that point. And so all the other ones would have stopped developing by now. And so the choices are those chromosomes from a practical standpoint, to kind of have like a last effort to screen for conditions that might make it to birth still. Okay. And so those are covered from what I understand. I don't know if there's any age cutoff in the California legislation, but those are covered in California. If they were out of pocket, I believe, and my team did get me some pricing, I want to say that out of pocket costs are somewhere in the hundreds, like low hundreds, 200 to 300. Carrier screening, in our practice, we have contracts with some of the carrier screen companies in the orders of hundreds, 200 to 300 for full panel carrier screening. Karyotype somewhere in the hundreds also per karyotype per parent. And then embryo testing is in the thousands typically. Okay, and then it depends on how many embryos you're testing.
Yeah. Okay, awesome. Well, if anyone listening would like to do that, you can get OC fertility. Okay, cool. I know this is a bit out of left field as a question, but we actually get it very frequently in our own DMs and comments on social media. So we get a lot of questions around sort of like questioning the paternity of the baby. So can genetic testing show who the father is? Does it kind of can paternity testing kind of come with the other tests that you mentioned, like NIPT?
I don't believe you can do it with I'm not sure if you can do it with NIPT. I have to think about that. I guess it depends on the type of NIPT you do.
Okay.
But we certainly can do it with the embryos. And I suppose you could do it during pregnancy. That's possible because, so the way they do paternity testing is there's sections between genes called single nucleotide polymorphisms, or SNP. That's the best kind of way to do paternity testing. There's other ways, but that's the most reliable way because those sections are less likely to change generation to generation. And you can kind of think of them like DNA fingerprints. And so they get passed on, though, from generation to generation. And so they use those sequences to identify parental DNA. So you can do it for the for the maternal DNA and for the paternal DNA.
Okay.
So if you had DNA from the father or DNA even from the mother, you could trace it back to the child. So SNP technology is used to do that. And so I suppose you could certainly do that during pregnancy too. But we can do it at the embryo stage, and that's some labs, including ours, will use that for patients to have confidence that the embryos are in fact their embryos, which I'm sure you've heard in the media. There's some instances where embryos are not people's embryos, and so that's one way to give confidence to patients who are in your practice that their embryos are their embryos.
How frequently is that a concern?
You know, it's in the media. It sounds like it's more common. I think I did a literature search looking at it, and it does occur, but who knows how often. I think we'll discover that as we have more genetic information, but I think what I saw was somewhere around 1% probably.
Oh, okay.
So I'm not sure how accurate that is.
Yeah, so 1% is when people ask for that kind of testing, or when there's
they've
an exact...
identified that, like I saw some literature where they were calculating how often does that probably happen.
Oh my gosh.
I don't know if that's accurate, so don't quote me on that.
Oh, wow. Yeah, we get similar questions around stem cell banking. Like, we work with a lab that's ABB accredited and FDA aligned and such. So there's definitely a lot of, like indexing to make sure that every kind of compartment correlates with the patient. But we get a lot of questions around that too.
It's reasonable to think about those things because humans are doing some of the tasks, and you want to make sure that there's no room for, or very little room for human error.
Yeah.
Right?
Yeah, definitely.
So we do we think about that in our, I think about that a lot in my practice, especially with the lab.
Right.
In ways to minimize those risks.
Right. Okay. Awesome. Well, I know that genetics tends to be pretty mathematical, but when we searched genetic testing, one of the frequently asked questions on Google was who has stronger genes, the mother or father. So
I didn't like that question.
do you have a take on that, or is it generally pretty mathematical?
Well, it's actually, it was interesting because I did kind of look it up to think about it because, if you think about what my first instinct was, well, the X chromosome, you have more X material than Y material. Okay. So, and then you have mitochondrial DNA that comes from the mom. So I was thinking it must be more maternal. Yeah. But then I didn't want to be, I always say, don't assume, makes an ass out of you and me.
Yeah,
so
I think that too.
I'm not going to assume anything. I might think I know a lot of genetics, but I'm going to do my own research. So there was some interesting research I saw on, because one thing I have learned in the past, and I wanted to verify is, we think autism might come more from the paternal side, and in fact, that is also compatible with some of the other literature I saw that the male's DNA might be stronger in predicting things that are like epigenetically inherited. And so that's maybe stronger from the male side than the female side. I saw that in the literature. And then more recently, I guess there's been some studies, and I think that was in the New England Journal, looking at certain diseases might be more readily inherited from the male side. So men are more likely to pass on, 60% more likely to pass on things like diabetes, hypertension, and things like that.
Okay, interesting.
Yeah, the mitochondrial DNA might pass on more things like certainly some diseases, but also more personality things, which is kind of interesting. I didn't realize what other things it could pass on.
That is interesting.
Kids' temperaments, I guess. Can blame the mom again.
Yeah, no, I've been reading this book called The Female Brain, and it talks about, yeah, they do chat about autism and how it does tend to occur more in boys, because I think it mentioned it was correlated to testosterone levels. So is that why why autism would be more correlated from the father?
Well, no, from what I don't know a whole lot about autism, but what I do know is they think that it could be hereditary from the genes in the dad, and maybe they're triggered from testosterone. So that could be an epigenetic trigger, for instance.
Right.
So the genes that are passed from the dad, and age might be one of the factors, is what I understand. But I think people don't know exactly all the different factors involved. So it's probably a combination of different influences.
Okay. How would you define epigenetic?
Oh, epigenetics are things that, so you have your DNA, and then there's other things that can turn on or off genes.
Yeah.
For instance, environmental factors, and there's aspects like that turn on those genes, like enzymes, that can be influenced from your environment, for instance.
Okay.
So that's epigenetics. So you don't change the genes, you don't necessarily alter them, but you can activate them or inactivate them.
Okay.
And that can be passed on, the ability to activate or inactivate them.
Yeah. Okay, amazing. I believe you touched on this briefly, but does genetic testing show gender, and which genetic
yes. Yeah, for sure. So we were talking about PGT. So PGT aneuploid screening is counting chromosomes. And so humans, we have 23 pairs of chromosomes. Other animals have more or fewer chromosomes. Well, the 23rd pair is the sex chromosomes. So XX would be female, XY would be male.
Okay.
And so we can detect that as early as the, I hate to use male or female, I guess. That's the sex, not necessarily the gender. But we can detect that as early as the embryo stage. And then during pregnancy, the NIPT will identify XX or XY.
Okay. Yeah, isn't that frequently done during IVF? They'll tell you how many embryos you have for each gender, and then you can kind of choose, or sex rather.
Yep.
Okay. Interesting.
Yep. And there could be mistakes on those sex chromosomes that can lead to disease. So like Turner's syndrome sometimes is compatible with life with minimal problems, but it can also lead to heart defects. And so it's definitely something we screen for.
Right. Okay. How long does it typically take to get genetic testing results for pregnancy? When should folks consider getting, for instance, like prenatal testing of each individual parent, things like that?
That's a good question. Yeah. So the karyotype and the carrier screening of the egg and sperm parent can take anywhere from 2 to 4 weeks to come back. So you really want to do that as soon as possible, in my opinion.
Yeah.
If the parents identify, say, that they both are carriers of, say, cystic fibrosis, and they intend then to screen embryos for cystic fibrosis, it takes time to create what we call probes, which are kind of like the map for the embryos. It can take 2 to 3 months to create those probes. Some people may not want to do that. They might say, we'll take our chances because we know it's only it's a 25% chance our child would inherit it, and we'll wait till we're pregnant and then test the pregnancy with a CVS or amniocentesis. Most of our patients want to test embryos, but certainly there's some people out there who, one, they can't afford to, or two, they're not comfortable with that technology.
Okay.
Okay,
cool. What are 3 diseases that can be predicted by genetic testing? You mentioned Down syndrome,
Yeah, so there's different. So there's chromosome diseases like Down syndrome, and that's trisomy 21. Another chromosome disease would be like Edwards syndrome, which would be trisomy 18. I guess I'll go on to another type of condition, cystic fibrosis, which would be a single gene disorder.
Right.
Okay,
awesome. So what happens if you do get back a test that is positive? For instance, Down syndrome, I feel like is especially common. What's the general protocol from there?
So if you say you did an NIPT, which is a non-invasive test, you'd want to corroborate that with a more intentional test. So most people would be referred to a high-risk OB doctor called a perinatologist. They generally would then offer the patient either a CVS, chorionic villus sample, in order to get more cells from the fetus, or an amniocentesis.
Right.
Generally, that'll also be conducted with a more thorough ultrasound, because, it's tricky when you have a genetic or a chromosome error. There's a range of expression. And so we know that there's going to be some abnormalities, but it's hard to know the extent of those abnormalities. So when parents are trying to make decisions about what to do, you want to see on imaging, what's the expression? Can you see a lot of defects already, or are those defects not detectable yet? Because that might help parents make decisions about what they want to do with that pregnancy. Can you see fatal heart defects? Do you see obvious brain defects?
Right.
And so the DNA is part of the equation, but the imaging is really important too in terms of making decisions, because the imaging gives you information about expression of that DNA.
Okay. So what's sort of the decision tree at that point? Is it like termination is one of the options?
It can, yeah. So luckily in California, that's still one of the options.
Okay.
And then some people may choose not to terminate.
Yeah.
So it's interesting because some of my patients will say, my doctor doesn't think I should be doing genetic testing in pregnancy because I would never terminate a pregnancy. And my answer to that is, that's not the only reason to do genetic testing in pregnancy, because even if you're not going to terminate, being at a certain hospital with specific team might lower the incidence of complications at birth and might give that child a higher level of, their outcome might be better. So you want to prepare as much as you can.
Yeah.
And two, you might change your life knowing that you're going to have a child with potential disability. You might choose a different household. You might want to be closer to family. You might choose a different job or choose not to work. So I feel like being prepared is still really important, whether you choose to terminate or not. And so, burying your head in the sand isn't always a good idea.
Yeah.
And it could alter, the extent of the illness in your child to not know what's going on. So I'm a big believer in knowing more than less in that situation, because I think it can actually help your child do better if you're prepared, So I feel like it's important to know and not to just say, we'll deal with it when the time comes, because if you don't have the resources that you need, it could actually be detrimental to the situation.
Yeah, that makes sense. In California, at what point do you have an option to terminate or not?
24 weeks.
Okay. And at what point do these tests typically detect these kind of diseases?
They start as early as 10 weeks.
Okay.
That's the screening. And then the CVS typically, some places can do as early as 11, but typically not before 12.
Okay.
And then amnio, typically 15 to 18 weeks is the earliest.
Okay. So you mentioned that a lot of parents will normally get a screening, and if it's positive, then they will elevate them to a higher risk OB or perinatalogist, and then at that point they'll do an amnio or a more definitive test. And
they may or may not do it, because so imaging might detect something.
Yeah.
And so if they see something on imaging, they may or may not follow it up with amnio or CVS.
Yeah, I guess I was wondering, how frequently is it that the second test reveals something that the first test did not indicate, or
that there's a false positive on the first test?
Yeah.
Honestly, I'm not sure, but I'm going to say it's probably single-digit percentages where the first test detects a problem and the second test says it was a mistake.
Right. So the second test is mostly to just understand how frequently or severe it's expressed.
It's the second test is to make sure the first test was not a false positive.
Okay.
Because if it's a false negative, you're not doing the second test.
Yeah.
So the follow-up to the first test to make sure it's not a false negative is your anatomy scan.
Right.
And then the other thing to realize is that not all congenital defects are genetic in nature or chromosomal in nature. So we're only screening for a small subset of all the potential defects, although it is a large population of them. About 3% of congenital birth defects have no known genetic cause.
Okay.
And those hopefully would be detected at ultrasound, anatomy scans.
Yeah. I feel like when thinking about genetic testing, Down syndrome in particular is a really frequent concern.
Yeah.
So I have a couple questions about that.
Do you know why that one's always?
Because of high age?
No, that one is because we see children born with Down syndrome because it's less fatal. So the other chromosome errors don't make it to birth.
Right.
So that one we see children born with trisomy 21.
Yeah, that makes sense.
Okay.
Okay, interesting. So yeah, who is generally at higher risk for Down syndrome and having a baby with Down syndrome?
Yeah, that's a good question. So in fact, everyone's at risk, young and old, but the frequency goes up as we get older.
Okay.
But as we get older, the types of chromosome errors that occur in our embryos or as a result of our aging eggs are more complicated usually, which prevents us from often even getting pregnant.
Yeah.
And often we'll just miscarry.
Okay.
So certainly the percentage goes up as we get older, but we also miscarry more often as we get older.
Okay. Are there other risk factors for Down syndrome, like stress, that tend to play a role?
Not that I'm aware of. Yeah,
Okay.
Not that I'm aware of. It's about 1 in 1,000 on average, the risk of Down syndrome.
Okay. Interesting. So what new research is being done on the genetic causes of infertility? Like, I feel like a lot of infertility kind of comes from an unknown source. So I guess I'd be curious to get your take on, how people are perceiving that, how research is progressing there, what you view as even the top causes of infertility.
Yeah, I mean, age is clearly one of the biggest causes. Women, we're born with all our eggs, and those eggs age with us. And as they age, they don't function as well. And so they're more susceptible to making mistakes during fertilization, passing on too many or too few chromosomes to the embryos, resulting in chromosome defects. So that is, from the outside seen as unexplained infertility. So when patients present to their gynecologist or their fertility specialist, we do a whole host of tests, and those tests could come back normal, and they get diagnosed as unexplained infertility, but it often can be related to undiagnosed egg quality. We can't diagnose that from the outside. So the only way you really diagnose that is through IVF, where you detect then the errors in the embryos. But aside from that, we do think, so once patients, if they go down that road, you might discover that through IVF. But certainly there are patients who go down that road and still don't succeed. And those are a smaller subset, and there's probably something else going on there. And I think there's some newer data saying that there could be some variants in DNA that increase people's risk for either embryo quality issues, not specific to chromosome number, or increased risk for miscarriages. And so I think there's a lot of evolving research in that area that's really interesting to kind of close the gap on what we know about infertility and what we don't know. And then I think also certainly the environment, it's changed so much, and that's probably another big area that's influencing how we reproduce and effects on our reproduction.
Right.
Yeah.
I've read
another area that I'm interested in for sure.
I've read some literature around hormone disruptors being more frequent in American diets specifically. Do you have any thoughts on that?
I mean, I don't know a whole lot about that. One of my colleagues who's big on this kind of stuff, Dr. Laura Shaheen, she does a lot of work on that.
Okay.
I think that's really interesting work. And I certainly would agree that there's likely to be a big component, not just with fertility, but with all our aspects of health,
like autoimmune disease.
For sure, like cardiac health, cancer risk, immune disease, and directed towards increased inflammation in our body. So I'm a big proponent of whole foods, plant-based, minimally packaged, minimally processed foods. I'm not a vegan, I'm not a vegetarian, I don't like using those terms, but I eat meat, I eat fish, I eat everything, but kind of a Mediterranean as much as possible, limiting packaged foods and trying to your body is dependent on what you put in it, and so certainly I eat junk food sometimes, but I try to make that a minor part of what I possess, and we try to direct our patients the same way.
Yeah.
Because your cells, your fertility cells are, they're in the same, whatever petri dish as the rest of your cells, and so you want all of them to be functioning at top speed.
Right. Yeah, I've seen a lot of rhetoric amongst the biohacking community around like seed oils and them being endocrine disrupting and hormone disrupting. So that's super interesting.
For sure.
And we've actually had a perinatologist on our podcast before, Dr. Steve Rad at Cedars, and he was saying, it was super interesting because I had a lot of our highly requested questions around like what are the biggest causes of miscarriage and the biggest causes of stillbirth, because he specializes in stillbirth and prevention of that. And he was basically like, we have no idea around any of it. So, yeah.
Well, aside from chromosomal, which I still think is the number one, there's definitely a gap. So there's this one group that we know is the major cause. And once you've ruled that out, I think there's kind of this gap that we can't explain. That's an area I really find interesting. And again, another one of my colleagues, Dr. Ruth Lottie, does a lot of work towards that. And she, she's taught me a lot in that area. She was actually one of my mentors. But I think the uterine environment plays a big part of that. And I think people sometimes don't spend enough time exploring the uterine environment from a more kind of detailed level. Like, bacteria in the uterine environment and scar tissue in the uterine environment. I think all that can contribute, especially in the early stages, not necessarily advanced stages like a perinatologist would be dealing with, but in the first trimester stages.
Okay, awesome. Cool. I'd love to move into history of disease as a subcategory of genetic testing and fertility. So what medical history is generally needed when you are pregnant, and what is particularly important for physicians to take a look at? What do you sort of screen for within someone's medical history?
I screen for everything. I literally do. I ask them everything. I want to know what medications, what medical illnesses they've had. I want to know about their family history. I want to know their habits, smoking, marijuana use of any kind, THC, CBD, edibles, drinking, coffee. We ask everything. And work habits, travel habits, exercise, too much, too little. So to me, moderation is really important. And I always tell my patients, we don't know how long it's going to take them to get pregnant. So we try to find kind of a happy medium between not making them crazy, because, some of the things, I have some colleagues who are very strict with their patients about lifestyle things, and that can be really stressful for women. You tell them not to do anything, and those are sometimes stress relievers for women. So I always remind patients, it could take a month, it could take a year to achieve your goals. And if you like to exercise to relieve stress, I want you to keep exercising, but we might modify how you exercise. I don't want you to be dormant, just, sitting around as a couch potato, because that's not necessarily healthy either. And if you like to have, a glass of wine once in a while, I'm not going to say zero alcohol until you're pregnant. So we don't want to do excess, of course. I don't want you going out and doing 4 tequila shots in a night, but we want you to be healthy in moderation, because I think moderation is really the key to health to me. Like, you don't want to do anything in extreme. And so I think that's really important for guiding patients, and they're looking for guidance, and they don't want to feel guilty about their decisions and their choices, and they need an outlet. They need to have a healthy outlet. And so if you're too strict, I think that can be really hard for them.
Are there any kind of common lifestyle red flags or even medical history red flags that you look for, like history of certain disease?
Like high blood pressure. Weight is a huge thing. Weight is tough. And where we're at in Newport, can be the other way, like too thin. So over exercisers and really thin. So you don't want to be too thin or over exercising, and you don't want to be too heavy and under exercising. You kind of want to have that sweet spot. PCOS is a big thing, and it's not. And sometimes it's hard to detect PCOS, especially in people who are really maintaining very high quality lifestyles. And so even though they're very healthy, it doesn't mean they don't have the endocrine disorder that can be contributing to their fertility problems. So maybe they've managed it well with lifestyle, or maybe they still have an underlying hormonal imbalance that's harder to look for because they don't have the classic signs of it. So it's interesting, the influencer that I mentioned earlier, whose story I've been following through her IVF journey. It's I think she got diagnosed with, or it was experiencing, I think it's HSSA, something like that. OHSS? Yes, OHSS, yes. Ovarian hyperstimulation syndrome? Yes. I always joke, that's our purpose when we do IVF. We do want to hyperstimulate our patients, but the goal is to make it controlled. So she probably had it uncontrolled. So they had like a pretty emergency egg retrieval, and then she wasn't feeling well. It was, and I think they, it wasn't able to go as planned, like the implantation, it kind of threw off their timeline. So the goal is to make it controlled as you can. Okay.
What are the most common kind of diseases that you might detect during pregnancy or disorders or anything like that?
Yeah, so back to your prior question about medical history things. So PCOS is really important because it does predispose women in pregnancy for things like diabetes.
Yeah.
So preconception, we're screening them for diabetes. Many of them won't have diabetes necessarily, but they could be pre-diabetic. So they could have kind of borderline signs of diabetes. High blood pressure is another common one we want to screen for. We don't often see that in the first trimester unless they're hypertensive preconception. And again, where we're at, we have a lot of patients who are very health conscious, so we don't see a ton of that, but we certainly do see some. So we're always checking their vital signs, making sure at least, we've screened them for that once in treatment. And then other things, things that get missed, autoimmune conditions can be commonly undetected, and we pick up a lot of that in our practice, especially for patients who have implantation failure or recurring miscarriages.
Okay. Another common question was, what should I ask my health insurance company when pregnant? What can possibly be covered given certain medical history?
Why are they so difficult? No, just kidding. Luckily, I don't have to deal with that much. I have a great team who deals with that. But yeah, so I think I've been doing this long enough, running a practice long enough, I have some ideas, and I think it's obviously changing. I think the good thing is now there's some plans that are dedicated to fertility, which I think is great because they can speak the language. In the past, the companies that offered fertility benefits often didn't understand fertility, and so it was really challenging for the administrative team to even get information from them. So now, especially if you have a plan that has like a carved out fertility benefit, it's much easier to navigate. So I think that's first and foremost. Do you have a plan that has a carved out fertility benefit, or is it like your traditional, Blue Cross Blue Shield? So like a carved out benefit could be Maven, Carrot, those are examples, ARC. So a carved out benefit, I think, allows you to really have an advocate because that's what their purpose is.
Right.
And so I think when you have those kinds of carve outs, it's easier to navigate. If it's going to be more traditional, like Blue Cross, United, Anthem, it's a little trickier to navigate. But really, you want to enlist your employer, if that's where you get it from. They should have a human resource person, and make sure you have your policy to look for things that are included, so inclusions, exclusions, and understand the language. Like, is medical services included specifically for the physician's services, the laboratory services, the pharmacy services.
Right.
You want to really be able to identify those services separately.
Okay.
Patients often get confused, especially like even looking at my practice, or if they used to come to our practice and say we're doing IVF, they don't even realize sometimes they have to go elsewhere to do the retrieval, and they don't realize that it's a different entity. And even now it's on site, they might think it's the same entity. So we really try to show them that they're separate entities, and sometimes one entity is covered and one entity is not, or one entity is contracted and one entity is not. And that's not always up to us. That's sometimes up to the insurer or the actual insurance company or the employer who they're working for.
Right.
And so they really have to do their due diligence, and unfortunately it's their agreement with their insurance, and the employer contracted that insurance. So we really don't have much we can't really fix that. We can't do much about it. Okay. So we do our best to try to navigate that for them and to try to advocate for them, but at the end of the day, there's only so much we can do as the middle person.
Right. Okay. Interesting. Another common question is, what is G and P in pregnancy?
Oh yeah, G. So G is gravida.
Okay.
That's how many times you've been pregnant.
Okay.
And generally speaking, we try to stick with clinical pregnancies, so like positive pregnancy test, preferably like blood work,
Okay.
So, home UPT is, you could include that, but usually as a physician, we like to see blood to confirm it, just so you ensure it's not a false positive. And then the P's, depending on which system you use, and I think the system you used was the TPAL, I like to call it. So P's are para, that's kind of detailing what happened to that pregnancy. So T, the first number, is term pregnancy. The next number is preterm pregnancy. The third number is stands for abortion, whether it's intended or interruption of pregnancy, miscarriage, so spontaneous abortion, or ectopic. So it kind of encompasses all those three. And then the last is living children. So we could kind of abbreviate that TPEL, term, preterm, abortion, and living children. Okay. So for instance, if you had twins, your living children might be higher than your pregnancies.
Okay. What is that system generally used for?
So it's how we communicate in our medical charts.
Okay.
The number of times someone's been pregnant, the number of births they've given, and how many children they have, how many miscarriages they've had, whether those births were delivered early or at term. And for us, people often think your due date, 40 weeks, is anything before that's preterm. Actually, anything before 37 weeks is preterm.
Okay, because it's EDD.
Yes, so your estimated date of confinement is really going to be 40 weeks, but you have 3 weeks before that is still considered term, and then 2 weeks after that.
Okay.
So it's post dates or pre dates, but it's not preterm until you're before 37 weeks.
Okay, awesome. Another really common question, or commonly asked question, was what is G3P1011?
That's what we just went through.
Okay, got it.
So let me see. So wait, where was that one? Let me see. So let me explain that one again.
Okay.
No, that's the one we just went over.
I think you called it TPAL?
Yeah, TPAL,
okay,
that's my abbreviation.
That
was in med school.
As G3P1.
Yeah, so G is gravida.
Okay.
3 is 3 pregnancies.
Oh, right. Okay.
P is para, so births.
Okay.
1 is so the mnemonic to remember it. So T is term pregnancy. So this person had 1 term pregnancy.
Okay.
0 preterm pregnancy. So that's your P.
Okay.
1 abortion, and then 1 living child.
Okay.
So the mnemonic to remember those numbers is TPEL.
Okay.
That's my med school.
Okay, good to know.
We do a lot of mnemonics in med school.
Yeah.
I don't think I would have survived without them.
Okay, cool. Well, my last question around history of disease and sort of receiving or testing positive for a certain disease is, can stress cause birth defects?
Well, I don't know I'm not sure that stress specifically can cause birth defects, but medical illnesses can cause stress.
Right.
So indirectly, I guess.
Okay.
But I wouldn't say directly as far as I've seen.
Right. Okay, awesome. Well, the last segment that I wanted to move into is quality control in IVF, because I feel like that's something that across your site with OC Fertility, quality control is really emphasized. So yeah, what does quality control mean to you in IVF, and how do you emphasize it in your work?
Yeah. So, I mean, this is something I think about a lot because my business depends on it.
Right.
So we actually, we don't specifically license with ISO, which is a standard that's kind of international standard that's used, but we follow the criteria in there. There's many governing bodies. There's CDC, SART, CLIA, CAP, tissue bank licensing. There's lots of different governing bodies that kind of monitor what we do. But more importantly, we try to create internally measures that limit risk for mistakes. So things that I try to do that over the years that I've learned is, we have 1 procedure suite, 1 collection room, so that there's just not an opportunity physically for things to get mixed up. For me, that lets me sleep at night. So we might not do as many cases at a time, but that's okay. I'm okay with that, because then I can really become confident with chain of custody, So, and then the embryologists are only dealing with 1 egg sample and 1 sperm sample at that one time. And then you have stations, and other labs are bigger and they do this well too. I'm not saying that others, but for me as an individual owner of a practice, that's how I can manage it comfortably.
Right.
And so we have, you have different stations for different patients. So when you're handling one patient's sample, you're at one station, and another patient's at a different station. So you just make sure that everyone's handled at a different station. You have 2 witnesses for every step. So you make sure that 2 people are identifying tissue at all times. You have imaging, so that you're documenting with imaging what people are doing, so that you can go back and reference it. You're using multiple sources of identification. So it's not just a name. It's going to be a name, a date of birth, a number. You have multiple ways of identifying people, and then identifying the tissue.
Yeah.
So that you have lots of those instead. So that's kind of the way to make sure identities are safe. And then your equipment is, obviously has to be checked frequently. So you're on a schedule to check your equipment. We kept our equipment. We had options of where to put our equipment. Mm-hmm. And the big thing with that, I'm sure people heard about the egg thaw that happened at one of the centers.
Oh, yeah.
I decided to keep our backup generator in the suite. So it's top of mind. So it's like right there. It's hard to miss. And so it gets checked all the time. And so it's literally right next to where our tissue is being stored. Mm-hmm. It's in a separate room, but there's two rooms, one where the tissue is being stored and one where the energy that supports it is being kept, so that it's hard to forget. And so there's always, and there's like a log that keeps it. There's an alarm system that's automated if there's anything going wrong with it, and it not only sets off in the suite, but it sets off remote to contact multiple people. And then, of course, you want to test your staff. You want to make sure that your staff are following minimum proficiencies and capable of doing what they're supposed to be doing.
Right.
We have lots of policies and procedures and what I like to call scripts, so kind of standardizing how people engage with patients. I try to really, sometimes I guess makes it, staff sometimes don't love it, but we have very standardized ways that we want them to engage with patients, especially for routine things, so that then they can spend time dealing with their emotions individually. But with the things that we do repeatedly, I have kind of very standardized ways of managing those, so that patients are getting the same experience and that we know that they're being handled in a very specific way. And we don't miss things that way.
Right. Okay.
And we do rely a lot on automation, for that's been great actually in some ways. It's been hard to implement, but we do rely a lot on our systems to automate, especially providing information to patients, verifying identities with patients. We rely a lot on our computer systems and programs and apps to do those things. Okay,
cool. I'm curious if there are any questions or qualities you think folks should look out for if they're currently engaging an IVF clinic, just to make sure that they can gauge for quality control as a patient.
Yeah, luckily, most practices in the U.S., you can't really survive if you're not doing a good job. Yeah. And most of us have to, the CDC requires us to report to them. I think there's fewer than 5% of clinics, if I'm correct. Certainly single-digit percentage of clinics that don't report, as far as I know. I've been reporting since starting my practice. SART is another organization that's within. It's not mandatory to report to SART or to be a member of SART, but they do. It's a fertility specialists organization to self-regulate. Yeah. So it's kind of supposed to be a higher level than even the CDC, and so being a member of SART kind of gives you another layer of professionalism in what you do, and so I think just making sure that your clinic has met those minimum, they should definitely be part of CDC and reporting to CDC, and to if they really want to be confident that they're members of SART, I think that would be good. Okay. Make sure they have all their licensing for tissue banking and members of, they've FDA regulated and haven't had any issues with the FDA. Yeah. And then I think just feeling comfortable with who's taking care of you, and if you have any weird feelings, those instincts are probably important to tend to. Right. I think that
we have a tissue bank license too.
Yeah, you have to, right? With what you do. You guys have a lot of tissue.
Yeah, for sure. What do you think improves egg quality in particular, even outside of the lab, for instance, if there's anything that the parents can do?
Oh yeah, for sure.
Lifestyle-wise, anything like that.
So back to what you eat. I think that's really matters. There's a whole list of supplements we provide for patients, but I honestly don't think, if you can get that through your food, I think that's the best way to go. So, lowering inflammation in the body, taking in good nutrients, nutritious foods, I think that's really important. So we do provide kind of a list of do's and don'ts in all our new patient packets, and then we work with a lot of nutritionists and complementary healthcare providers in our community, and we provide references to our patients. I always say that's their expertise. I kind of have a general recommendation, but for patients who really need to work on those things, we refer them to our complementary healthcare workers. And then there's a list of things that we advocate if they want to try, but I'm not a big pusher of supplements and minerals unless they find it cumbersome to get it in their foods.
Okay.
And I'm certainly okay if they want to take those supplements. I don't have a problem with it, but I'm not going to, say you have to take these in order to have good egg quality. And then certainly taking out things that aren't good, especially in California, marijuana use is legal. But there's some question about its safety and healthfulness with eggs.
Right.
And I think part of the problem, just like anything, it's not regulated well. And so you don't know what else is in your product. And I have seen some patients who do, a cycle while they're using CBD or THC products and their egg quality is crummy.
Oh, wow.
And then they abstain for 2-3 months and then they have better egg quality. I can't, it's anecdotal. Wow. I can't, I don't have a study, a randomized trial.
Yeah.
But there's, very likely or possibly something in that didn't help with their egg quality. Maybe they were more conscientious about everything in those 2-3 months, who knows?
Right.
But I can't advocate for something we don't have data on.
How do you define egg quality? Is it like likeliness to implant? Or...
Well, egg quality is complicated because age is a huge factor, right? And you can't unage. I always tell people, I wish we could. Everyone wishes they could. So we can't unage, but you can certainly age faster by doing bad things. And so you just want to try to be as healthy as you can and recognize that some of it's just going to be age related and it is what it is. And then there's certainly young people who have poor egg quality. People don't age the same in all parts of their body. You have young people who get more wrinkles.
Right.
Young people get more gray hair. Young people are going to have ovaries that age faster, even if the rest of their body doesn't look like that.
Yeah.
And so some of it you're not going to have much control over, but you certainly can have some control by making things worse.
Okay.
And so I always say you've got this pile of stuff you have no control over, this pile of stuff you do. So do what you can here without making yourself crazy. And then accept what you can't hear and move on, do it, whatever you can.
Okay.
So egg quality primarily does come down to the chromosomes, which you can screen in the laboratory, but it also comes down to cell function that we can't necessarily easily detect or identify, but probably has a lot to do with inflammatory processes in the body.
Right. One of the frequently asked questions when you search quality control in IVF is how can I improve my egg quality in 30 days? So I know you mentioned diet, limiting drug and alcohol use. What other tips would you have?
So like sugar. There's been lots of studies looking at, and I think that's true with cardiac health and I'm not a big sugar person in general, but sugars, especially processed carbs, have been found to be unhealthy for egg health and cell health in general. And then unhealthy fats, like you want healthy fats. So plant-based fats are good. Yeah. Animal fats are not good. So like avocado has a lot of fat, but it's good fat. So I think that those two things, and there's some really cool research I've seen from a cellular level at our meetings. Probably you want to stick with more of a Mediterranean. If I had to pick, I don't like these fad diets, but Mediterranean diet that limits animal proteins, not eliminates, but limits to small portions. If you want to eliminate it, I have patients who want to be vegetarian, fine. Vegans, I always worry because sometimes they end up with a lot of processed foods, and I don't think processed foods are good. Right. So nuts are good fats, avocados are good fats, occasional meat products, fish, I love fish. But you also got to be careful with the fish because of the mercury and the contaminants that you can find in that. So I would say, bulk up on healthy fats and eliminate unhealthy fats and sugar. Okay.
Another question that we had was around what is a 5AA embryo quality versus 4AA?
Yeah, so that's complicated. So first and foremost, I always say, was the embryo genetically tested or not? Because that's your first, I don't even talk about grading or stage until we know about whether the embryo was genetically tested. If the embryo is genetically tested, that's your first and foremost, most important question. Okay. So if I have an embryo that's been genetically tested, then I look at this kind of thing, right? And then we rank them based on grading and stage. So generally speaking, a 5AA is going to be better than a 3AA. A 4AA and a 5AA, it's a toss-up depending on what day it took to get to that. Because these are blastocyst grading and stagings. A blastocyst embryo can reach that stage on day 5, 6, or 7. 8, usually they're done by day 8. And so the stage and grade also matters what day it achieved that. And so generally I'd say a 5AA is probably better than a 4AA, but it could be a toss-up depending on what day it got there.
Yeah.
And then in 5AA embryo quality, to be specific, the first number describes how expanded the embryo is. So that we talk about is stage, and it's not the same as the day the embryo reached a blastocyst stage. People get really confused, and it is confusing, but the day of blastocyst formation is not equivalent to the stage. Okay, they're two different things. So day of blastocyst formation is day 5, 6, or 7. Stage is going to be typically 1 through 6, but usually we really, in our lab, we don't use anything less than a 3. So it's 3, 4, 5, or 6. Okay? And then your letters, there's 2 letters. The first letter describes what the cells look like that are called the inner cell mass, ICM, and those are the cells destined to become the baby down the road. And the second letter are what describe the trophectoderm cells, and those are the cells destined to become the placenta, and those are the cells that get biopsied for embryo testing, PGT. So those are ABCs, okay? So A is obviously better than a B.
Yeah.
Okay? So you want an expanded embryo. Generally 5 is better than a 4. 6 is when it's starting to actually try to implant.
Okay, awesome. My last question is one of the also largely searched questions is what is the controversy with IVF? Which is actually kind of interesting.
Do we have a whole week to talk about that?
I honestly didn't know there was a lot of controversy with IVF. I mean, I guess I could think about it from like a Roe v. Wade perspective, but yeah, what do you view as sort of the main controversies within IVF?
I mean, that's kind of a new controversy, I think, more recently. It's funny because that didn't really come up until recently, but I think there's a lot of, ethical concerns around IVF, which I find really interesting.
Yeah.
Stem cell research, my daughter is, she did that project as a senior in high school, and kind of asked, it was really, I found it really interesting that she picked that project, but looking at how the government doesn't support stem cell research in that area because it's so controversial.
Right.
There's like this intersection of medicine and politics and religion, and it's hard to separate.
Yeah.
So I think that's a big area that we're going to see a lot of in the future. How do you, where do you define life, and where do you define, medicine?
Yeah.
And how do you deal with so many, the other kind of flips that people talk about is there's a lot of children who don't have homes, and why are we doing treatment and giving people children when there's so many children who don't have homes? But I don't think that's for us to always decide for other people.
Right.
And so I think there's a lot of controversies in IVF, and I think that we're going to see a lot more of that. I think the future is going to be interesting too, because historically IVF was for people who couldn't get pregnant, but now with genetics, IVF is going to be opened up for disease prevention. Yeah. Right? And so people who can get pregnant but want to prevent certain diseases and to even eliminate diseases in their families and their family lines are going to be doing IVF, not for infertility, but for eliminating, illness. Right. So when you talk about disease prevention, there's no really kind of earlier way to prevent disease than IVF. Yeah. You can start eating better in your youth, but if you identify genes that cause heart disease or diabetes, you can actually select for them in embryos potentially. Right. And that's kind of crazy when you think about it. Yeah. So that there's going to be a lot around that ethically, I think.
Yeah. So I guess like the designer baby controversy.
For sure. Yeah. Polygenic gene testing, and what do you do with that? Right. I mean, it's available now. We've talked about should we or shouldn't we incorporate it into our practice. And I think at some level we should, especially with conditions that can be debilitating. Yeah. But, it's not perfect, and you're not going to have perfect answers with those tests either. You're going to have risk ratios, so this embryo has a 60% risk of expressing this disease because those conditions are, they're multifactorial. They're not just based on a gene being turned on or several genes being turned on and off.
Yeah.
But it's still interesting, and I think people have a right to at least have the information.
Okay. Yeah.
But you're going to have kind of the haves and the have-nots too.
Yeah.
And that's really tricky too.
Yeah. Well, do you happen to serve patients out of California?
Oh yeah, we definitely do.
Okay, awesome.
Yeah.
Well, in the case that someone is or is not based in California, how can they find you if they're looking for a reproductive endocrinologist or OB?
Yeah, we do. Well, we don't do OB care. We do. Okay. We do first trimester OB care only.
Okay.
I always say we make them now. We don't deliver them anymore. We just make them. So we are ocfertility.com, and we do telehealth medicine. We do a lot of international and out-of-state care, especially now with Roe v. Wade. I feel like we're getting a lot more out-of-state patients.
Right.
Yeah. And we're definitely open to that.
Okay, awesome.
Yeah.
Well, thank you so much for being here.
You're welcome.
I really appreciate it. This was amazing.
Nice meeting. Nice getting to know you.
Yeah, you too.